Welcome, everyone. Thank you to the Disability Rights Education and Defense Fund's overview of California Advancing and Innovating Medi-Cal Initiative, otherwise known as CalAIM. DREDF is a national nonprofit law and policy center led by people with disabilities, dedicated to advancing and protecting the civil and human rights of disabled people. DREDF is also an IOLTA-funded support center, offering disability-related expertise to the California legal service community. My name is Michelle Uzeta. I am of counsel with DREDF, and I focus on advocacy involving public entities, housing, and transportation. My co-presenter today is Silvia Yee. Silvia is a senior staff attorney at DREDF, where her work has included projects to increase physical and programmatic accessibility and disability awareness in the delivery of healthcare services, as well as impact litigation to increase access for people with disabilities in myriad aspects of public and private life. Obviously, there's more information about CalAIM than we can cover in the hour that we have today. So we will be providing links to resources as well as a PDF of the PowerPoint within the next day or so. We are also going to try and leave a couple of minutes at the end of the presentation for questions and answers. Everyone is on mute right now, so please drop your questions in the question and answer box as we go along. Next slide. So why does this presentation matter? Why are we choosing this today? There's a couple of reasons. People facing housing insecurity disproportionately include people with disabilities with multiple marginalized identities and people who need or rely on long-term services and supports, including home and community-based services. People who are unhoused disproportionately include people with disabilities with multiple marginalized identities and people who need or rely on long-term services and supports. And third, because people with disabilities transitioning from institutional settings require enhanced coordination of care and long-term services and supports to prevent physical health and behavioral complications, including the risk of post-release homelessness. So when we use the term housing insecurity, what do we mean? We mean people who are in the following types of situations: where the majority of income goes towards rent, where there are inadequate housing conditions, or you're living in neighborhoods susceptible to natural disasters. Household insecurity puts households with members needing long-term services and supports at greater risk of losing their home altogether. So we know that housing security is vital for the health, well-being, and community integration of people with disabilities. We also know that people with disabilities and households with members who need long-term services and supports are often rent burdened, meaning the majority of their income goes towards rent, often 30 to 50%. Households with members needing long-term services and supports are 3 times as likely to face inadequate housing conditions than households without disability related needs. For example, housing units may have leaky roofs or walls with cracks and holes, faulty electric wiring or plumbing, broken refrigerators, and things like that. Additionally, households with members needing long-term services and supports are almost twice as likely to live in neighborhoods with a higher susceptibility to natural disasters than households without disabled members. And this includes things like floods, hurricanes, and tornadoes. All of these factors contribute to placing households with members needing long-term services and supports at greater risk of losing their housing altogether. So it's important for us to be aware that often the people who rely on frontline housing advocates like ourselves are people who either utilize or would benefit from long-term supports and services, including home and community-based services. The link that is in this particular slide is to a 2020 brief from the Community Living Policy Center at Brandeis University, entitled Unaffordable, Inadequate, and Dangerous Housing Disparities for People with Disabilities in the U.S. Has a lot of great data and information about housing insecurity for people with disabilities. And with that, I'm going to turn it over to Silvia for the next couple of slides.
Thanks, Michelle. Could we advance to the slide that has the heading, "What is LTSS and HCBS?" Okay. Thank you. So we are talking about LTSS, long-term services and supports, and home and community-based services. When we're talking about long-term services and supports, we are talking about a very broad range of health and social services that provide varying levels of assistance for children, adults, and older adults with disabilities. And the intent of LTSS is to help individuals with disabilities perform routine daily activities. People who utilize LTSS have all kinds of disabilities, including cognitive disabilities such as dementia or Down syndrome, physical disabilities that include multiple sclerosis or spinal cord injuries, sensory disabilities, including blindness or deafness, mental health disabilities, such as depression or post-traumatic stress disorder, and also chronic conditions like cancer or HIV/AIDS. As well, an individual can have any combination of these disabilities, along with other conditions such as diabetes, hypertension, or asthma. When considering the range of healthcare that people who use LTSS need to stay functional in the community, we can see how having LTSS needs makes it acutely important to have a home. And at the same time, having LTSS needs can make it harder to find housing if the housing situation offered is very restrictive about the ability to have personal care assistants come in and out, for example. LTSS, long-term services and supports, can be provided in institutional or home and community-based settings. Institutional settings include nursing homes and intermediate care facilities, and home and community-based settings include an individual's apartment, community centers, assisted living facilities, and so forth. So we see that there's a diverse group of users that use LTSS, that LTSS itself includes a broad range of services and supports. Now, let's look a little bit about what we mean by institutional versus home and community-based services. So it's true that LTSS can be provided in the community, and when that is done, it is usually called home and community-based settings, or HCBS. Most of this presentation is focused on HCBS, as that HCBS is much of what CalAIM is looking at. It's when California is entering the CalAIM initiative. HCBS includes assistance with activities of daily living, such as eating, bathing, and dressing, common self-care tasks. It also includes instrumental activities of daily living, which are also sometimes called household activities, things like preparing meals, managing medications, and housekeeping. And HCBS also includes a range of benefits that are intended to help enable people with disabilities across all ages to remain healthy in their communities. This may include residential services, adult day healthcare programs, home health aid services, personal care assistance, case management services, and more recently, housing-related services, which is what we will be talking about shortly. Historically, it's important to recognize what many disability advocates call the institutional bias. There has been a bias from the beginning of Medicare and Medicaid towards institutional placement. In recent years, however, states have really begun to utilize HCBS more, recognizing that people want to have home and community-based services and remain in their services where possible, that people who are aging want to age in place. Generally, health and disability rights advocates strive to help people receive community-based services and supports to help people with disabilities maintain their independence, and their social connections. And that is a hallmark of disability rights advocacy. Over the last 20 years, there has been a shift toward serving more people in home and community-based settings rather than institutions, due in large part to a growth in beneficiary preferences for home and community-based services, as we've noted, and also a growth in states' obligations because of the Supreme Court's Olmstead decision, which found that the unjustified institutionalization of persons with disabilities violates the Americans with Disabilities Act. So this change is happening, this orientation towards home and community-based services is happening against a backdrop in which Medicaid required states to provide institutional care. Institutional care is, under the Medicaid Act, something that states must include in their state plans, in their state Medicaid plans. On the other hand, home and community-based services is optional. It's something that states can include, and that a lot of federal policies have more and more encouraged states to include, but it is not a requirement under the Medicaid Act. And this is what is often referred to as the institutional bias, and something that disability advocates have been working against for many, many years. The final thing to bring up here in this discussion of backdrop is to talk about home care provider inequities. And this is a critical part. Home care providers are essential to home and community-based services. Obviously, they are the personal care assistants. They are the workers, the employees that allow people with disabilities to stay in their homes. But despite the challenging nature of the work and the very significant contribution that home care makes to our society, job quality tends to be very low. Wages are low. Home care has historically not been valued or respected as real work. In part, it's because of a social expectation that home care is supposed to be a private activity. The family is supposed to take care of home care needs. It's outside of the economy. And it's the devaluation of home care also occurs because of the devaluation of women of color, who do much of a great majority of this work, whether the work is paid or whether the work is unpaid. And you often have women of color informally providing care to their family while also being employed in low-wage situations as home care providers. In 2015, the median hourly wage of home care workers in California was $10.05, compared to $18.88 for other kinds of jobs. So having looked at some of these situations, we'll move on to the next slide. It's against this backdrop that we're looking at LTSS and HCBS. Just to say that 1888 is the median for all workers. You can see how much lower it is, and the economic situation of home care workers is a disincentive to working in the field, even though there are many skilled workers who are great at their job and love what they do. Next slide, please. So, oh, right, I'm sorry, California's major home and community-based services. By far, Medicaid is the largest provider of home and community-based services in the country. Medicaid, which is called Medi-Cal in California, is the largest provider of home and community-based services in California. It assists people with, so Medi-Cal, you must be a member of Medi-Cal, you must be a Medi-Cal beneficiary to receive home and community-based services under Medi-Cal. There's very limited coverage under Medicare for long-term service and supports, whether institutional or home and community-based. And that's something that very few people, that the public in general, is often not aware of. And there are even fewer options in the private insurance market, which is facing many, many problems with economic viability at this point. In California, there are a number of different home and community-based services programs that can help individuals with disabilities and older adults who receive Medi-Cal to remain in their homes, or help them return home after a period of being in a hospital or in a nursing home. The federal Medicaid statute and other provisions in the Social Security Act offer California, like other states, broad statutory authorities under which HCBS can be offered to Medi-Cal beneficiaries. These authorities include the Medicaid state plan, which every state participating in Medicaid has to have a Medicaid state plan that lays out the services they provide through Medicaid. And it also, HCBS is also offered through HCBS waivers. So looking first at the state plan. The Medicaid state plan refers to the part of the Medicaid program that generally follows certain program benefit rules that are set out in the Medicaid statute. These rules require states to cover selected benefits under the traditional Medicaid state plan and gives states the option to cover others. So as you remember, we talked about the institutional bias, and that's again what this is referring to. State plan benefits are an entitlement, which means that if someone meets the eligibility requirements, they must receive the services. They can't be denied because there are already too many people in the program, for example. So in-home supportive services, or, just to go back, so optional services or services provided under waivers don't work quite the same way, as I'll detail in a moment. Looking at the IHSS, or the in-home supportive services program, that is Medi-Cal's version of the Medicaid personal care benefit. IHSS is the largest of California's HCBS programs and can be used in conjunction with other HCBS services. So IHSS is also an entitlement. If someone qualifies, meets the requirements for IHSS, they must receive the services, though it can take some time to start them and to actually find providers. That's a practical delay, not a legal delay. IHSS services include housekeeping, meal preparation, laundry, grocery, personal care assistance such as bathing and grooming, as well as paramedical services, help with injections or administering medications or wound care. And it can also include protective supervision. Protective supervision is a service that people with certain disabilities can qualify for, where an individual can receive up to 24 hours, up to 24 hours of supervision a day if they cannot be safely left alone. I mentioned this one because this is one of the few in-home services that county agencies often tend to try and arbitrarily reduce. It's good to be aware of that one. And IHSS advocates who work in the field are aware of how much counties can try to reduce the service upon without a valid reason for doing so. IHSS is really a jewel in the California Medi-Cal crown. It is unique in that it is self-directed. It is consumer-directed, which means that the care recipient is the employer who can hire, supervise, and terminate his or her caregiver's employment. Very few Medicaid consumer assistance programs actually follow this model, even though the concept is a large part of the independent living movement. In IHSS, personal care providers can also have their spouses or the parents of minor children and other relatives be their personal care assistants. Recipients have the option of hiring independent providers, including family members, to be their personal care providers. Personal care providers can include these relatives, and the majority of IHSS home care workers, actually 64%, are family providers, meaning that they do care for a family member. IHSS is administered by county-based public entities called IHSS Public Authorities in cooperation with the California Department of Social Services. It is available across ages and population groups who meet the needs criteria established by the state. IHSS is part of the state plan. Home and community-based service waivers are a different thing. A waiver is when CMS allows a state to use Medicaid funding to experiment with programs other than what is required in the state plan. And because home and community-based services in general are not a requirement under the Medicaid Act, they're an option. States can use Medicaid funding to experiment with programs other than institutionalization, as long as there's no additional cost to the federal government. The waiver, it's called a waiver because in general, Medicaid sets out requirements for Medicaid services. It says, the Medicaid Act says Medicaid services have to be statewide. They have to be comparable across populations, and Medicaid members have to have a freedom of choice in where they get services. When a state proposes a waiver, they can waive some or all of these Medicaid requirements in order to come up with an experimental program that they believe will help, that the state believes will be beneficial to certain populations or to certain groups of people or in certain geographic areas. HCBS waivers are the primary authority that states use to provide HCBS, and states continue to develop new waivers that are targeted to particular populations. HCBS waivers are programs that provide additional medical and social services to specific groups of individuals, limit services to specific geographic areas of the state, and provide medical coverage to individuals who may not otherwise be eligible under traditional Medi-Cal rules. And that's an important thing to know because waivers are useful when they allow participants who have higher income eligibility limits than regular state-time Medi-Cal. However, HCBS waivers usually also require the participant to meet a certain level of care to utilize the waivers. That's part of the budget neutrality. And if a waiver participant would have qualified for institutional care, they draw down a certain amount of funding from the federal government. Allowing this same participant to receive HCBS in the community instead of being in a nursing home or another institutional setting means that the person who is in the community setting cannot be using more money from the federal government than they would have if they were in that institutional setting. One more thing to note is about the wait list. Medi-Cal beneficiaries are not legally entitled to waiver services, even if they meet all the financial, functional, and medical criteria. Under Medi-Cal HCBS waivers, California must specify to CMS the maximum number of people they will serve in the waiver during a year, and they cannot exceed that number without obtaining permission from CMS. Because there is a high demand for waiver services, California has established waiting lists for waiver services. The demand is often greater than the number of people who can be served. CalAIM and whole person care is one of these HCBS waivers for which California has applied. California Community Transitions is another waiver. So in the next slide, what are we're looking at CalAIM. Just a brief overview of the CalAIM. So late in 2021, I believe, the Centers for Medicare and Medicaid Services approved the the California Department of Healthcare Services request for a 5-year extension of its Medicaid Section 1115 waiver and a 5-year extension of its Medicaid 1915B waiver. These Medicaid waivers are really integral to the California Advancing and Innovating Medi-Cal, CalAIM project that was launched in January of 22. Medicaid has always been the primary driver of innovation in home and community-based services, and much progress has been made over the past 2 decades to improve HCBS for older adults and people with disabilities. And more recently, a lot of attention has been looking at people who are at these intersections and experiencing homelessness. CalAIM was born out of a few different pilot programs that focused on care coordination for Medi-Cal beneficiaries with complex needs. So the desire was to provide a set of intensive care coordination services across multiple delivery systems to provide a person-centered approach to care. These initiatives pushed the boundaries of a traditional healthcare delivery approach and began to formally consider the impact of social determinants of health on health outcomes and experience of care in California's Medicaid program. This is definitely an attempt to be an innovative approach. CalAIM is pretty far-reaching, and it's a multi-year plan to transform California's Medi-Cal program and to make it integrate more seamlessly with other social services. It's led by California's Department of Healthcare Services, DHCS, which is also the state's sole Medi-Cal agency. The goal of CalAIM is to improve outcomes for the millions of Californians covered by Medi-Cal. And the focus is supposed to be on those with the most complex needs. Next slide, please. Enhanced case management is a critical part of CalAIM. It envisions care coordination as a new managed care benefit. And it's also important to realize that Medicaid in California is very much operated through managed care. About 85% of Medi-Cal beneficiaries in California are in managed care. And managed care is where members receive care through a specific entity and through that specific entity's network of providers. So care coordination has not necessarily in the past been a part of the managed care benefit package. It hasn't been a part of what, hasn't always been a serious, substantial part of what Medi-Cal managed care plans have to offer as a benefit to their members. CalAIM has established the enhanced case management benefit, and it is supposed to provide intensive whole person care management and coordination to address both the clinical and the non-clinical needs of Medi-Cal members with complex needs. Enhanced case management will be accounted for in the capitation rates that managed care plans receive. And that's one of the hallmarks of managed care plans. They charge a per member per month fee for the members that are in their plan. It allows the state to have a more certain budget, if you will. It provides funding for the Medi-Cal plans per member per month, and the Medicare plans have to meet the requirements of all its members in that month and over time. Managed care plans now must provide enhanced care management to members if they request it. Enhanced case management is intended to ensure that enrollees with complex needs are identified and engaged by someone who understands their goals will develop a plan in partnership with them and their providers and actively connects them with the clinical and non-clinical services and resources that help them meet those goals. Every Medi-Cal managed care member enrolled in ECM, Enhanced Case Management, is supposed to have a dedicated care manager. It will be available to Medi-Cal managed care members who meet ECM population of focus definitions. The core components of ECM that are universal for all populations of focus include, actually, I will go on to that in the next slide. They're detailed more there. But the key point is that plans will now have the obligation to identify members and to assign them to ECM providers, who are then going to be responsible for coordinating and managing care. And that's also where the housing part comes in. One of those benefits, housing is a key social determinant of health, intricately linked to health and well-being. And there's finally a recognition of that as we're moving forward with CalAIM. Next slide, please. So here are some of the enhanced case management, ECM, I apologize for the typo in the slide, core services. Plans are supposed to engage in outreach and engagement. They have to tell people about this benefit. They have to tell their members that there is such a thing. Plans are supposed to engage in comprehensive assessment and care management planning. There should be coordination of and a referral to community and social support services. There must be an enhanced coordination of care, warm handoffs, knowledge of all the available benefits that a member may qualify for, and knowledge of how those benefits should interact and be provided in a way that is seamless for the member. There should be member and family supports. Also, health promotion as typical part of preventive care, and comprehensive transitional care. Members will go through various transitions, entering a hospital, leaving a hospital, going in through a transition from being a child, entering into adult, out of pediatric care. Members go through various transitions, and enhanced case management should recognize and adapt to these transitions as well. And we'll go looking on at the next slide of the CalAIM populations of focus. So an obvious question would be, well, how does one qualify for this great benefit? The CalAIM is focused on certain populations, and it phases in its care for the availability of ECM for those populations. ECM will be phased in by county and by population of focus from January 2022, this year, January, through July of 2023. It's 18 months, beginning with counties that have already participated in whole person care and the HHP projects. The California Department of Healthcare Services has set up this schedule of phasing in. DHCS has designated 12 specific populations of focus for the ECM benefit, and managed care plans are free to add to that list at their discretion, but they don't have to. California Department, The populations of focus for children and youth include the following. 1, children up to age 21 who are experiencing homelessness. 2, high utilizers of healthcare services. 3, children and youth with serious emotional disturbances, or identified as having a clinical high risk for psychosis or experiencing a first episode of psychosis. 4, enrolled in California Children's Services or California Children's Services whole child model with additional needs beyond the qualifying condition that allows them to be in California Children's Services. They could be also children or youth who are involved in or with a history of involvement in child welfare, including foster care up to age 26, and children and youth transitioning from incarceration. Health plans are required to automatically authorize all Health Homes Program members and whole person care members who are currently receiving care coordination through the whole person care pilot, and reassess them within 6 months to determine if they still benefit from enhanced case management level care coordination. So there's intended to be a kind of a soft transition for those individuals who have already been receiving care coordination through these programs. They should continue to get it for another 6 months through the CalAIM and then be reassessed. And all managed care plans are strongly encouraged to offer in lieu of services in all counties beginning on January 1st, 2022. And we'll be looking at in lieu of services very soon too. In January 1st, 2023, there should be enhanced. Oh, well, let me go through the slides as well. I've gone through the children and youth, but the slides actually detail the populations of focus that should be looked at in the healthy homes and the whole person care counties. So already at this point, individuals and families who are experiencing homelessness, high utilizer adults, and adults with significant mental illness or substance use disorder are supposed to be providing enhanced case management, receiving enhanced case management as a population of focus. On July 1st, counties who did not have the health home projects or whole person care pilots are also supposed to be providing enhanced case management to these populations. As of January next year, enhanced case management should be available in all counties for these populations of focus. Individuals transitioning from incarceration, both adults and children or youth, members eligible for long-term care and at risk of institutionalization, and nursing home residents transitioning to the community. By July 1st, 2023, enhanced case management should be available in all counties for children and youth populations. And the next slide. Managed care plans will contract with community-based entities, county agencies, federally qualified health centers, primary care providers, behavioral and health entities. This also could include organizations such as independent living centers to provide care management services. And this is a critical part of CalAIM, which is intended to recognize that the managed care plans themselves don't necessarily have the connections. They are not the trusted providers for individuals who are experiencing homelessness in the community, for individuals of color, for people with disabilities. This is for people of, for SOGI individuals. Community-based providers are the ones who are trusted providers. Those who are actually in their communities, who have relationships already with people who are homeless or at risk of homelessness. So the managed care plans are supposed to be contracting with these community-based entities. However, the care plan is supposed to remain the primary responsible entity for coordinating care across multiple medical, behavioral, and social service systems. just there's really a pretty long list of who can be enhanced case management provider, and that is in the notes to the slides as well. It includes Indian Health Services programs. It can include county behavioral health providers. It can include many organizations that work in the community. And finally, the plan must designate a lead care manager for each member who's actually receiving enhanced case management. And I'm going to turn this back to Michelle. Thank you.
Thank you, Silvia. Okay, so moving on to community supports. In addition to ECM, which Silvia just went over, another key feature of CalAIM is the introduction of a menu of community supports, otherwise referred to as in lieu of services in managed care. These are services that Medi-Cal managed care plans are strongly encouraged, but not required, to provide in lieu of or as a substitute for utilization of other services or settings, such as hospital or skilled nursing facility admissions, discharge delays, or emergency department use. These community supports build on the whole person care pilots and the Health Homes program, HHP, and expands access to services that were previously available only through home and community-based service initiatives, while addressing health-related social needs. It replaces the whole person care and home health models to scale interventions to a statewide care management approach. So referring to the slide, these community supports are intended to be medically appropriate and cost-effective alternatives to services or settings that are covered under the state plan. The Department of Healthcare Services has pre-approved 14 types of community supports, and those are in a slide coming up. Community supports are optional, as we said, for health plans to provide and for Medi-Cal managed care members to receive. And each community support has its own eligibility criteria. Managed care plans in California counties were able to launch these supports starting in January of 2022. Next slide. Housing services have historically suffered from legal ambiguity over what specific services Medicare funds are allowed to pay for. CalAIM's community supports they provide a new funding pathway for housing services that have already been piloted under whole person care, and they can target services at a specific high-risk population, including people who are unhoused. Three key housing supports that the managed care plans can provide as community supports are listed on the slide. The first is housing transition navigation services, for example, assistance applying for and finding housing, assistance with signing a lease, securing resources for setup, utilities, move-in, and reasonable accommodation, assistance with requesting those types of things. The second is housing tenancy and sustaining services, for example, early intervention around behaviors that might jeopardize housing, dispute resolution with landlords and neighbors, again, reasonable accommodations, assistance with recertification support. And I know a lot of us who work with people with disabilities know that these types of supports are really essential for us in doing our advocacy and to keeping our clients in housing and helping them secure housing. And the third is housing deposits. More about these housing related services can be found in a policy guide that I will include when I circulate the PowerPoint and the list of services. Thank you. For the next slide. The list of pre-approved community supports are on this slide. They're geared primarily towards people who have behavioral health conditions, are experiencing homelessness, or otherwise have complex chronic conditions and social needs. And for people who need this slide read, I will go through it real quickly. The 14 pre-approved supports include recuperative care or medical respite, day habilitation programs, for example, independent living skills kind of programs that teach cooking, cleaning, shopping, nursing facility transition and diversion to assisted living facilities, community transition services, personal care and homemaker services, environmental accessibility adaptions, which refer to home modifications, respite services, medically tailored meals or medically supportive food, sobering centers, asthma remediation, short-term post-hospitalization housing, housing transition navigation services, housing tenancy and support and sustaining services, and housing deposits. These new optional services are designed to address the social drivers of health. I think Sylvia used that term earlier. That means the conditions in the places where people live, learn, work, and play that affect their health and their quality of life. These services also recognize that there are many situations where existing healthcare services are just not enough to support an individual's well-being. You know, for example, someone who's unhoused and diagnosed with kidney failure may not be able to tolerate needed dialysis if they don't have a safe place to recuperate. And community supports can be used in such a situation to provide recuperative care, assistance securing more permanent housing, and that just hasn't been the case traditionally with Medi-Cal. Community supports give managed care plans financial flexibility to meet the needs of members in new, more patient-centered ways. They're available to any eligible members, regardless of whether they qualify for ECM. The two programs are not exclusive. The list of pre-approved community supports is not exclusive. Managed care plans can offer additional supports subject to department approval. Next slide. Slide here on providers. Providers of community supports have to have experience and expertise with providing services in a culturally and linguistically appropriate manner. This list on this slide is an example of the types of providers that Medi-Cal managed care plans may choose to contract with for housing related services, but it's not an exhaustive list of the types of providers that can be offering the services. So on the slide, the types of providers listed are providers for services for individuals experiencing homelessness, mental health or substance use disorder treatment providers, including county behavioral health agencies, social service agencies, vocational agencies, affordable housing providers, social supportive housing providers, and federally qualified health centers and rural health clinics. I always have trouble with that word. Kicking it back to Silvia for a couple of slides on eligibility.
Thanks, Michelle. So I'm just checking which. Sorry, I'm having trouble with my own computer. So CalAIM eligibility. Extended, ECM and the in lieu of services will only be available to Medicaid beneficiaries enrolled in managed care plans. This is a majority, of course, of Medicaid beneficiaries, but it's important to recognize that it's also an incentive to enter managed care. CalAIM is limited in scope. It is intended to apply only to Medi-Cal's most vulnerable members, people who are experiencing homelessness, people leaving jail or prison, people who have serious mental health disabilities and or are frequently in and out of hospital emergency rooms. The enhanced case management and in lieu of services are separate initiatives. And there are some Medi-Cal members who will only qualify for one or the other. They each have their own eligibility criteria. Again, to keep in mind that health plans are required to automatically authorize every Health Homes program member and every whole person care member that is currently receiving care coordination. Those are the members who are supposed to be walked over into enhanced case management for at least 6 months. And managed care plans are strongly encouraged, but not required, to offer in lieu of services in all counties beginning on January 1st, 2022. The next slide. ECM and community support eligibility. So as we've noted, the 85% of Medi-Cal beneficiaries are in managed care plans. So these benefits will be available to a majority of the population, or a majority of the Medi-Cal members can qualify for them. Because ECM is intended for the highest risk, highest cost plan members with the most complex medical and social needs, eligibility is limited to members who fall within at least one of the specific populations of focus. So for the purposes of this presentation, we're really focused on individuals and adults who are experiencing homelessness, people who are at risk of institutionalization, and youth involved in child welfare. The community services service definitions set specific eligibility criteria for each category of community support. While managed care organizations are not required to offer community services, once they do decide to offer some or all categories of community services, members will have the right to file appeals or grievances if they request community services that are offered by the managed care plan, but are denied because of a plan determination that the service is not medically appropriate for the individual or is not cost effective. Community services are also subject to the state fair hearings process. Another important thing to keep in mind. I'm turning it back to Michelle to provide some examples of what we've been talking about.
Sure, we only have a couple of minutes left. I'm just going to read through, Diana, if you can go to the next slide, a couple of examples of how this might play out in real life. And then there's a couple of questions in the chat. So the first example comes from California Health Care Foundation. J.A., age 55, slept in her car briefly before moving into a temporary shelter in an Oakland motel. As a Medi-Cal patient, J.A. was eligible for CalAIM. Caseworkers called her regularly to walk through the steps to get into housing, from cleaning up her credit to attending housing fairs to filling out rental applications. When J.A. found a one-bedroom in Hayward, the program paid her first and last month's rent and helped her secure a federal emergency housing voucher that reduced her rent to $960 a month. Sounds great on paper, huh? Next example, and this comes from the California Department of Healthcare Services itself. Frank has struggled with addiction while experiencing homelessness in San Francisco for 4 years. Frank visited the emergency department frequently. In 2020, Frank contracted COVID and continues to experience long-term symptoms. CalAIM's ECM connects Frank with a care manager. They can meet at a nearby food bank to make plans for him to see his mental health provider to get his medication adjusted. The case manager can also connect Frank to a local community supports provider who will help him secure safe, supportive housing. Last example, Maria is, and this is from California Healthcare Foundation. Maria is a 75-year-old Medi-Cal managed care plan member, lives at home, but is at imminent risk for nursing facility placement. She may be eligible for in-home support services, but the approval process could take several months. Maria's managed care plan diverts institutionalization through community supports by providing meals, personal care, and making her home more accessible with ramps and grab bars. So those are 3 types of examples where these kinds of services may come into play to help people get or maintain housing. Silvia, I don't know if you saw, there was a question in the Q&A from Navneet. Who is contracted to be case managers and what is their baseline training regarding housing issues and rights for people with disabilities? I do not know the answer to that, but it seems like an extraordinarily important question because these case managers are really key in this process. And I'm wondering, Silvia, do you have any idea?
Yes, I mean, that is a great question, Navneet, and I would actually need to check on this for sure, but it seems to me that I don't think we know yet, honestly, whether plans are going to be, the degree to which plans are really going to be relying and giving discretion to the community-based organizations with which they contract. I think it's very clear that the plan should have case managers that know what they're doing, obviously, and that is aware of housing rights and will actually work and enhance the work of the community-based organizations with which they work. I feel like we don't know enough yet as to how that's really working, and I'm not sure yet on the ground how that's working, and that's what your question prompts me to really try to find that out more. Just working through different, especially by talking to community-based organizations who are maybe working on this right now. I think it's especially looking at this intersection between housing rights and people with disabilities. This when a community-based organization can be very familiar with housing issues and maybe not as familiar with disabilities and some of the self-determination principles that underlie a lot of disability rights. A good case manager should be familiar with how these things intersect and be able to help mediate some of the issues that arise. Do I know that's happening? I don't actually know if that's happening. I'm sorry, that doesn't answer your question, but that's where I'm on that right now, and I will look at that more closely.
It's interesting because the requirement that the services be provided in a way that's culturally and linguistically appropriate is also something that on the ground we have no idea if it's happening or not, or what training is being provided, or how counties are ensuring, or managed care plans are ensuring that this is occurring. So it is all interesting. Yeah,
it's so current right now, and it is very, CalAIM is very idealistic. I find it very idealistic in many ways. I root for a lot of it to work. I just don't know personally for sure how it's working.
There are two other questions in the chat. One is whether people who are Medi are eligible for CalAIM. I don't know the question. I'm not a benefits person, I'm a housing person, so this is all somewhat new to me, but hopefully Silvia knows the answer.
But I rely on you for housing information. So those who are eligible for Medicare and Medi-Cal, my understanding is that they are eligible, but then at the same time, there's also the dual eligible DSNPs, the dual eligible special needs plans that dual eligibles are being moved to. Yeah, I believe that my understanding is that CalAIM is intended to reach the most complex and vulnerable individuals, and dual eligibles are often right in that mix. Very complex medical conditions, and vulnerable for a number of reasons. It doesn't make sense to me that they wouldn't be eligible for CalAIM and those services offered. But I'm just trying to think of that intersection of how CalAIM applies directly to DSNP plans. So that's another question I will have to look at more carefully. And thank you for asking it, Kathy.
I think we have time for one more question. This one is, how can we find out which services the plans will offer so we can advocate for our clients to receive services? I tried to refer a client who's at risk of institutionalization to ECM at his Medi-Cal managed care. His social worker was unfamiliar with CalAIM, and this was in LA County.
I'm wondering when this occurred too, because of this phased in approach. I think it is possible that you're going to have plans, county and plan employees who are not quite familiar yet with CalAIM. I think it should be possible to escalate the request though. I mean, I'm trying to remember whether LA County was had a whole person pilot or. Yeah, I think it would be good to know. Please feel free to email either of us, and I'm wondering when the request was, and when you received that sort of response of, I don't know what you're talking about, from the social worker, because I think those are all potentially relevant to how to try to escalate it if your client is eligible for services. And I will do the homework of looking at what LA County, of what pilots they may have had. And it's possible your client should have been actually transitioned into ECM services. I just need to know sort of the timeline and the county. So I know the county, but the timeline would be helpful too.
Kim, she posted that it was in May of this year, but we're out of time. So maybe Kim, you can connect with Silvia outside of this presentation and talk further about that. It is 1 o'clock, so we will end this presentation, and I hope people got some useful information. Any questions that you have, there's also the materials that I'll be sending around with links. There's a lot out there on CalAIM, and hopefully those resources will answer a lot of your questions as well. Thank you, and everybody have a great afternoon.
Thank you.